Hello, Professor Ella Kazerooni. Thank you very much. It's an honor to have you here in this meeting. In this session, we discussed about the Fleischner Society white document and the guidelines and IPF guidelines from the European and American Thoracic Society. But basically, what I think that our associates want to know is when we have a CT with an UIP pattern, with a reticulation and no anicamic peripheral reticulation, when we have to biopsy or when we don't need biopsy. I think is the main questions that everybody asks.
Thank you.
It's a complex question, I know, but
it's a complex question. We thank you for the pleasure of being here. It's a great honor.
Thanks.
As we were discussing, the definite UIP pattern obviates the need for biopsy. The probable UIP pattern is almost as good as the probable pattern in predicting pulmonary fibrosis, but not quite as good, again, because of clinical context. The recommendation for surgical lung biopsy or transbronchial biopsy in the probable UIP category was a conditional recommendation, meaning that it's not required to move forward with a diagnosis of pulmonary fibrosis. And if you put it in clinical context with other things that are going on with a patient, other morbidities that they have, conditions like cardiovascular disease, severe dementia, whatever their other clinical context is, you can make the clinical diagnosis of IPF in the probable pattern on imaging without a surgical lung biopsy. So in that way, both the Fleischner and the multi-society guideline actually come out very similar when you read the fine detail in the language in the documents.
Yeah, I agree with that. Another question that maybe is in the minds of many of us, in Portugal we have significant amount of hypersensitive pneumonitis. And the hypersensitive pneumonitis that we have is chronic one. And sometimes with UIP or UIP-like pattern. So, in an example, for instance, a man, 70 years or 60 years, with CT with a UIP, a definitive UIP. And this man has bird exposure, for instance, or mold exposure. We have, especially in the north of the country, we have, because of the climate, we have many exposition to molds, indoor exposition to molds. Do you feel that we can guarantee that patients has IPF with even with definitive YP?
I think we understand less chronic hypersensitivity pneumonitis than we understand idiopathic pulmonary fibrosis. Much more work has been done in UIP and IPF. I think we're moving towards more understanding of HP in all of its forms. Most of the imaging has been descriptive without the detailed analysis of the actual findings. Most recently, our group at Michigan, led by Dr. Salisbury, published on this very topic about taking all the detailed features that are in an HRCT to try and come up with a better model for HP and chronic HP in particular. And it turns out there are some features, particularly if you have an axial distribution. We think about UIP as a peripheral, whereas hypersensitivity pneumonitis following bronchovascular bundles can have a more axial distribution, central to periphery. So we're starting to extract features that will make the diagnosis of hypersensitivity pneumonitis more confident. And I think in her paper she showed that with the criteria that were proposed out of a very large modeling study, a 90% confidence in the diagnosis of hypersensitivity pneumonitis using some of these features like axial distribution combined with or without air trapping. So the importance of expiratory CT scans becomes that much more important in working up interstitial lung disease. inspiration, expiration show you air trapping, mosaic attenuation pattern, plus the axial distribution of those two things really increase your diagnostic confidence towards chronic UIP that we haven't had before, and that's very new data.
Okay. And there was a question in the after the lectures that pointed about the future evolution of the radiological, the imaging exams. Do we have some evolution that it is predictable to go to the clinical practice briefly that helps to make this differential diagnosis between the fibrotic ILDs?
It's a very good question. We see a lot of artificial intelligence reports about trying different AI approaches to almost any disease pattern or any modality in chest imaging and body imaging today. We're seeing the ability to increase the diagnostic accuracy of more general radiologists who may be less attuned to the fine details and the understanding of pulmonary radiology and interstitial obstructive lung diseases. And these algorithms are able to extract features. The way I say it is they get more out of the images than what we can visibly see or integrate without these types of techniques. There has been work done in both obstructive and interstitial lung diseases to be able to extract features and get to higher diagnostic accuracy. I would say it's less about developing the techniques now as it is about getting them into practice. Getting them approved to use in medical practice and then integrating them into the radiologist workflow to be able to use them. But some of them are there already. I'm sure we'll see many more developed.